All right, thank you for joining for today's event where we are going to talk about skilled nursing facility documentation requirements. My name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education team, and I'm going to be your facilitator for today's event. And I'm also joined by other members of Provider Outreach and Education, as well as our medical review department, who are going to help with the chat as well as any question and answers for today's call. A few housekeeping items before we get started. As I mentioned briefly before, we have a training page on WPSGHA.com where you can find all the information for our live events. Again, Jennifer put that link into our chat. That link will also, if you back up one from that just into the training page, will take you to all training material, any upcoming events that we have, any presentation handouts that are available, and you can also view our encore presentation straight from our website instead of going to YouTube. So our encore presentations are generally available on our website for about 60 to 90 days, but they're always available on our YouTube page until the information either changes or something newer comes out. If you have questions for today's event, go ahead and place those in the chat at any time. And then after this event is over, and actually in a few moments, Jennifer's going to place a link to our survey into the chat. If you find you need to leave the webinar early, I do encourage you to take the survey when you leave, but otherwise you're going to have several different opportunities at the end of today's event to take it. On the screen now is our disclaimer that we have to show at all events. And our disclaimer basically says the information I'm giving you today is a tool to help you as our provider community. But know that Medicare laws, rules, and regulations often change. As a provider of Medicare services, you are obligated to follow the most current laws, rules, and regulations that are in place on the date of service that you are providing them. So CMS always has final determination of coverage. So on this slide, you can also access the CMS website by using this link to, see any laws, rules, and regulations as they are currently posted. Acronyms. This is just a list of acronyms that I may or may not use during this presentation. If I happen to refer to an acronym and you don't know what that means, just go ahead and refer back to this list. And if it's not on there and you don't know what it is, go ahead and put it in the chat, and Jennifer will help out and send that definition out to you. And again, just some more acronyms. And our objective and agenda. Why are we here today? My objective for today is that you learn about the essential documentation requirements for skilled nursing facility services under Medicare. So we're going to achieve this objective today by going through some of the basic coverage criteria, and then we're going to talk about the overall documentation requirements. Before we talk specifically about documentation requirements for skilled nursing facility services, let's review some of the coverage criteria. Now remember, your documentation is how you support you are providing services that meet Medicare's coverage criteria. On this slide, we list some basic coverage criteria that must be met for Medicare to consider payment for inpatient skilled nursing facility services. Now, this is for traditional Medicare. This is not for Medicare Advantage plans. They may have some different coverage criteria. So you have to follow those criteria as well if your beneficiary is under a Medicare Advantage plan. But we're going to break these down a little more in the upcoming slides. So some of the basic coverage criteria. There's got to be a 3-day qualifying hospital stay. this must be an inpatient stay. So observation or ER services don't count towards that 3-day qualifying stay. The patient has to be admitted within 30 days of discharge from that inpatient stay to your skilled nursing facility. They have to be receiving services for the condition that was treated in the hospital or that developed while in the SNF from the services, of the hospital. They have to be in a Medicare certified facility. They have to need skilled nursing or therapy services on a daily basis. And we're going to break down that daily as well. And then services need to be performed by or under those skilled professionals so we can say that they're actually receiving skilled services. And finally, they need to be certified by the physician. So the 3-day qualifying hospital stay. The beneficiary must have been inpatient of a hospital for medically necessary stay of at least 3 consecutive calendar days. I think it's easier to think of this as 3 midnights. So again, time spent in observation or in the emergency room prior to or in lieu of an inpatient admission to the hospital does not count towards the 3-day qualifying inpatient hospital stay. A person who appears at a hospital's emergency room seeking examination or treatment or is placed in observation and has not been formally admitted to a hospital as an inpatient, instead they're receiving outpatient services, those days, again, don't count. So for purposes of the SNF benefits for the qualifying hospital stay requirement, again, it's got to be an inpatient stay, and it commences with the calendar day of the hospital admission. Remember, when you're counting the days, admission day counts, but day of discharge does not count. That's why I say it's really easier to think about this as 3 midnights. Was the patient actually in a bed or in a chair or wherever, but in one of your Medicare certified beds in your facility or in the facility for 3 midnights? All right, as we move on, let's talk about the fact that the beneficiary has to be admitted within 30 calendar days of discharge. So that beneficiary must have been transferred to a participating skilled nursing facility at least within 30 days after discharge from the hospital, unless a medically appropriate exception applies. And we'll talk about that in just a second. So in determining the 30-day transfer period, the day of discharge from the hospital is not counted in that 30 days. So for example, a patient discharged from a hospital on August 1st. They're admitted to a skilled nursing facility on August 31st. That is within 30 days. The 30-day period begins on the day following the actual discharge from the hospital, and it continues until that individual is admitted to a participating SNF and requires and receives that covered level of care. So that's an individual who's admitted to a SNF within 30 days after discharge from a hospital, but does not require a covered level of care until more than 30 days after discharge, does not meet the 30-day requirement. But again, I said there's always the rules and there's always exceptions to the rules when it comes to a medically appropriate exception. So if there's an elapsed period of time, more than 30 days, that can be and is permitted for SNF admissions when the patient's condition makes it medically inappropriate to begin that active course of treatment in the SNF, like right immediately after discharge. And it's medically predictable at the time of the hospital discharge that he or she will require covered care in a predetermined period of time. So the fact that the patient enters a SNF immediately upon discharge from a hospital for either covered or non-covered care does not necessarily negate coverage at a later date. So assuming subsequent covered care is, was medically predictable. So the easiest example of this is maybe a patient that has some sort of injury to a lower extremity, and this person is going to be non-weight bearing for 35, 40 days. So no weight bearing, and there's no therapy or whatever that can be done. That person can still go to the skilled nursing facility and still have covered Part A care after that 35 days that the person was placed in, or that the physician predicted that that person could start participating in skilled care. And that is just an example of how, one easy way to think of how this medically appropriate exception could come into place. All right, the next condition of coverage. So a condition for which inpatient care was provided. To be covered, the extended care services must have been for the treatment or condition for which the beneficiary was receiving inpatient hospital services. That's including services of an emergency hospital, or for condition which arose while in the SNF for treatment of a condition for which the beneficiary was previously hospitalized. So in this context, the applicable hospital condition need not have been the principal diagnosis that actually precipitated the beneficiary's admission to the hospital, but it could be any one of the conditions present during that qualifying hospital stay. In addition, the qualifying hospital stay must have been medically necessary. So medically necessary will generally be presumed to exist, but we are going to, again, need to see that your condition for which you are now treating the beneficiary for at the skilled nursing facility goes along with the condition that they were hospitalized for. The diagnoses, again, don't need to match. We just need to see that, it is for the same type of thing. All right. And then the next condition of coverage is daily skilled services is the next condition that must be met. So skilled nursing services or skilled rehab services, or even a combination of these services, must be needed by your patient and provided by you as a facility on a daily basis. So on essentially 7 days a week basis, but there's indications, and we're going to cover those. So a patient whose inpatient stay is based solely on the need for skilled rehabilitation, you're going to meet that daily or 7 day a week requirement by providing those skilled rehabilitation services at least 5 days a week. So that's how you meet the requirement if you are rehab or therapy, PT, OT, SLP, or a combination of all of them. If your therapy services are provided less than 5 days a week, that daily requirement would not be met. So we'll talk later about what constitutes skilled services, but to quickly highlight daily skilled services, those are skilled nursing or skilled rehab services, again, furnished pursuant to a physician order. Now, for daily nursing services, those have to be the 7 days a week. So those services need to require the skills of that qualified technical or professional health personnel, such as your registered nurse, your licensed practical nurses or vocational nurses, your PTs, OTs, SLPs, audiologists. Those are all skilled personnel that can qualify to provide those daily services. And they must, again, be provided directly or under the general supervision of these skilled nursing or skilled rehab personnel to assure that the safety of the patient is achieved and you're getting the medically desired results that you want to achieve. Now, as we move on, the next component of coverage is physician-certified care. So this is the last condition of coverage that must be met. And you have to have services that are certified by a physician. So payment for your covered post-hospital extended care services can only be made if a physician or a physician extender, when it's allowable, makes the required certification and recertifications when those are necessary, and they meet them within the time frames that Medicare puts out, which again, we'll talk about as well. So the certification must clearly indicate that post-hospital extended care services or SNF services were required to be given on an inpatient basis, an inpatient in the skilled nursing facility. So Part A services in your skilled nursing facility is what I mean when I say inpatient services in this regards. And so the patient needs inpatient SNF services for their individual needs, and they need to be on a daily basis. And again, that for that condition which they received the inpatient hospital services for or condition that arose. So again, when your physicians are making their certification, these are the things that they need to attest to. So as a SNF, you're responsible for obtaining and retaining the required certification and recertification statements. The ABMAC, we can request the certifications, and we do request the certification statements to really assist us in determining the medical necessity of that inpatient stay. So it's your responsibility as a SNF to determine how you want to obtain those certification and recertifications. There's no requirement or specific form as long as you adopt some sort of approach in your facility that helps you, get that verification and those certifications and recertifications and make sure those requirements are met. Certification or recertifications can be entered on forms, they can be on notes, they can be in other records where, like, your physicians would normally be signing for things for the patient, or again, separate forms if you want. Except, as otherwise specified, each certification and recertification is to be separately signed. So a certification or recertification, again, must be signed by the attending physician or a physician on staff of the skilled nursing facility who has knowledge of the case, or by a physician extender. So that could be a nurse practitioner, clinical nurse specialist, or even a physician assistant. And it can be one of those that does not have direct employment or indirect employment with the facility, but who works in collaboration with the physician. So if you're a physician extender and your paycheck comes from the facility, you cannot sign the certification recertification. So as part of these overall requirements, the certifications must be done at specific time frames as well. So your initial certification is due at the time of admission. And the regulations go on to say, as soon thereafter as is reasonable and practicable. Well, what does that mean? That means you have to have it as soon as you can, but it must and has to be done by at least the day of the first recertification. The first recertification is at 14 days. So the recertification statement must contain adequate written record of the reason for continued need for extended care services. And it also has to have an estimated period of time required for that patient to remain in the facility. And any other plans that you have for the facility or for the patient where they're appropriate for any home care services. So those recertification statements made by the physician or physician extender do not have to include that entire statement. For example, if all the required information is somewhere in the progress notes that we can, link that up to, that's fine. But all of that information needs to exist. So again, your first one is due on admission or as soon thereafter as it's reasonable and practicable. The second one is due by the 14th day. As long as those two are signed on or before the 14th day, you're covered for the first certification and first recertification. Subsequent recertifications after that must be made at intervals not to exceed 30 days. And that's 30 days from the last signed date. So if you're using one of those certification, recertification forms, and you're populating in dates all the way down the form as a reminder based off the admission date for your physician, you may actually put your physician out of date compliance if that physician happens to sign early. Then the rest of the dates are not going to match up. So don't date the reminder until the last time they sign. So that's just a little piece of advice that I can give you that we see very often as an issue, because if the physician signs on the dates that you populated in, and then it ends up being wrong on subsequent reevaluations, you could have periods of time that there's no physician certification, and we, in essence, perhaps will not pay for services on those days because technically your patient is then not under the care of a physician. All right, so let's move on and talk about documentation and what components of documentation need to be present. All documentation needs to be complete and legible and timely. It also needs to be signed and dated. These are the most basic components of documentation requirements that must be met. So in the next several slides, we're going to discuss all the different types of documentation that must be present in your SNF claims and provide any information. This is all the information that would need to be included if any federal review entity came knocking on your door, Medicare, knock, knock, and they want to review your services. So we'll start with hospital records. This includes things like transfer sheets, history and physical, discharge summaries, surgical reports, any pertinent medication and fluid administrations, and documentation to support any skilled services as reasonable and necessary. So why are these so important? Basically, for PDPM, you need look-back information to help set your ARD date and capture the most amount of information for the best payment category. So is the patient the patient certified as coming to your SNF for a reason that they were, hospitalized for? That's going to be something we're going to use your hospital information for and look back into that. Can we see from that documentation if there were things like IV administrations that were in the look back period that you're capturing for your best payment rates? This kind of information is really important for completion of Section I in your SNF assessment. Section I includes active diagnoses, your primary medical condition. It uses a look-back information for your diagnosis identification and your diagnosis status, whether it's active or inactive. So that's why it's really important to do your due diligence and gather as much hospital information as you can to help set your best payment rate, to choose the best HIPS codes for, to report for the services that you provide. Now, physician documentation. So as we move on with the physician documentation, items that we would need to see for review includes anything that your doctors document on. So the physician or provider documentation of any type. Physician orders specifying the need for skilled nursing facility, and that's got to have a signature and a date. We need to see histories and physicals, admission assessments made by the physician, physician certification and recertifications for your skilled services with signatures and dates. If there's a delayed certification, if that's warranted, we need to see the reason for the delay, and the physician should be attesting to the reason for that delay during that certification period, and also include the signature and date that they are attesting to the delayed certification. Again, physician orders or your non-physician practitioner orders or intent, and all of that needs to be signed and dated. And finally, progress notes. So again, I can't stress enough, anything that your physicians document on or your non-physician practitioners would need to be submitted for review to help support your services as medically reasonable and necessary. So as we move on, the documentation in your chart must match what's captured on your MDS. So remember, there's certain sections of the MDS that affect your HIPS code or your payment. If you open this Briggs sample that is linked here on the slide, you can see that there are items that are highlighted in green. So that means it's going to affect your payment rate. If it's going to affect your payment rate, we are going to comb through your documentation to make sure you captured it and it is documented. So I'm going to open this just really quick to show you this example. Hopefully, if my computer plays nice, here we go. It's just taken a hot second to get there. Okay, so remember, the way skilled nursing facilities are paid is dependent on the information, and some of that information happens in the look back period. So starting with admission, we have to look back into what happened into the hospital stay. Here you can see there's a green box around here. That means that affects your payment. Section A, dates of hospital services. There is information in Section B, and I'm just scrolling through this really quick because I just want to highlight these examples. Again, observation and your dates. Section B, with your look back information about, if the patient's in a vegetative state, is the patient able to express themselves in the hearing, speech, and vision section of Section B. You can see there's quite a few things in Section C that could affect your payment rate. So all of these things, if they are pertinent, especially for the HIPS that you are reporting on your bill, we're going to go back and make sure exactly that this information is also documented in things like your assessment of the patient. And again, as you scroll through, You can see all the various different categories in this example from Briggs that all the areas that affect payment. And I'm not going to go through them, you know, all together, but I just wanted to make you aware of that and make you aware that I have put that example in there. All right. So your initial plans of care we need to see. Those need to be signed and dated by the team, by the people that completed those plans of care. Any assessments, reassessments, care plans that are made by any of the clinicians, so nursing, therapy, etc. Documentation to fully support the information in the MDS. And I talked about that, and I talked about how specifically we are really going to comb through your documentation if it affects your payment rate as well. And look back information in that prior, you know, that 30 days prior to each ADR. And, you know, just as an FYI, when we do a review of your skilled nursing facility services and it comes to your MDS, we ask you to submit a hard copy of your MDS. And we look at that and we compare that as well to what you have locked in the repository, and we make sure that all of that adds up to what you billed to Medicare. And if it doesn't and there's discrepancies, then we have to go back and look and see what we can find in your actual documentation to support it. And then we will pay you at the rate that is supported by your documentation, not necessarily supported by your what you have in your MDS, either hard copy or locked into the repository. We have to pay you at what's supported then by your overall documentation. All right, moving on. Nursing documentation. When it comes to your nursing documentation, again, we're going to look at all information that your nurse is documented on, especially those items, again, that affect payment. So items that are included are like your admission assessment, all of your nurse's notes, any medication administration records, and any treatment notes. Nursing affects many, many parts of the MDS, including Section GG, your functional abilities, Section H, like bladder and bowel, Section K, where it comes to swallowing and nutrition, especially when it comes to tracking things like parenteral or IV feedings or tube feedings or fluid intakes, your eyes and nose. M, skin conditions could impact your MDS and your assessments. Medications in Section M. And O, special treatments and procedures and programs. So these are just some of the important sections in your MDS that your nursing documentation is vital to, and it has to match what you captured on your MDS. So when it comes to rehabilitation services, it's important to remember, regardless of the dates of service that are under review, we need the initial assessment and plan of care when you submit documentation for review. If there are any reevaluations that have been completed because there was maybe a significant change in that patient's functional status, those must be submitted as well. Progress notes that are completed at a minimum of at least every 10 treatment days by the actual therapist must be submitted, as well as your daily treatment notes that support the actual minutes of service that were provided. So not just your total time in the rehab area, we need to see the actual skilled treatment time that was provided by the therapist or therapist assistant. So just keep in mind that rest time is not included. But even if I'm looking at 60 days into treatment, I still need you to submit the initial therapy evaluation and plan of care. All right. And then some additional documentation requirements, because we've talked about several of these when we talked about specific clinicians charting, like treatment records, and we need to have all those treatment records and plans of care from all services. We also spoke about how we need documentation to support each of the HIPS code bills and how certain areas of the MDS affect your payment rate. So some additional documentation that we didn't cover includes things like signature logs or attestation statements. This is highly important in cases where some of your documentation may still be handwritten. So we need to be able to verify whose signature is on that documentation and that it matches up with the appropriate person providing the services. If an ABN was issued, that would need to be submitted as well, so we can ensure it was issued appropriately. Excuse me. I've stressed how important it is to have the information that supports the MDS. So we need to see a hard copy of your MDS. And again, we're going to then compare that to what's locked in your repository, compare it to your billing, compare it to your documentation, and make sure it all matches. And then finally, a QIO letter if one was issued to your patient. So now let's move into some compliance. So in speaking about how the actual documentation, I've mentioned a little bit about how the doc is really used in the review, but let's dive a little deeper into this. The first part of our compliance review is going to be to make sure your patient's eligible for skilled Part A services. And that includes, did they have a qualifying hospital stay or a QHS? So once we know that they have a 3-day qualifying hospital stay, then we need to make sure that your beneficiary actually has benefit days available. Next, did your beneficiary come to the skilled nursing facility within 30 days? So did they meet that 30-day transfer? And if not, was there a medically appropriate exception in place? So we're going to look for that. Next, are the PDPM categories billed for the correct number of days? So this includes looking at the ARD dates, making sure that they are set appropriately as well. Next, we're going to look and see if there are any interrupted stays that affect your billing days. And finally, certification and necessary recertifications. Were they completed by the physician and were they done timely? Some of these checks are automatic checks that are going to be done by the system, but upon medical review, we verify these against the system as well. So as we move on, let's talk about how your documentation supports skilled services. As reviewers, we're going to look for documentation to support skilled services. So what do we look for? First and foremost, what requires you, your license, your expertise as a skilled clinician? Are you providing services that are safe and effective for the illness, injury, whatever condition that your beneficiary has? Are the services that you are providing, are they ones that require you to have a license? Are they ones that require your skills, your knowledge? Those are services that are considered skilled. And those services also have to be reasonable and necessary for your patient or your beneficiary on that day of service. So are they necessary for the treatment of that illness or injury or accident or whatever that condition was that brought that patient to you? Did you set goals? Are there goals for your patient that are reasonable? Are they achievable goals for your patient condition? Finally, are the services provided at the level billed? So let's look at some specific examples. CMS defines some of these things specifically as skilled services. And these can be found in the Benefit Policy Manual, which is 100-02, Chapter 8, Section 30.2.3. And Jennifer placed a copy of that, or a link to that section of the manual to Chapter 8 in the chat for you. So we're going to start with management and evaluation of the plan of care. So that includes developing, managing, evaluating a plan based on the physician order, supporting documentation, etc. So it takes you as a skilled person to make that plan. No one under you can make that plan. They can help you follow the plan, but they can't make that plan. That requires a skilled nurse, therapist, social service, etc. Next is observation and assessment of a patient's condition. Here, you're looking for the likelihood of change in your patient's condition. So again, that requires your skills, your knowledge, your licensure to be able to identify and evaluate those patient needs and be ready for possible modification of treatment or maybe even initiation of additional medical procedures until that condition stabilizes. CMS gives some examples, but one example is a patient with atherosclerotic heart disease with congestive heart failure. They may need close observation, especially if they're coming and they just had an exacerbation. They may need close observation by the skilled nursing personnel for signs of decompensation, abnormal fluid balance, adverse effects that may result in different prescribed medications that you need to speak with a physician about. There's many more examples under this heading that I encourage you to go to this section of the Benefit Policy Manual and take a peek at. Moving on to technical or teaching and training activities. So these require the skilled personnel to teach a patient how to manage their treatment regime. Like maybe they're starting on a self-injecting medicine, or maybe they're starting on the use of medical gases. Even prosthesis care for an amputee can be something that falls under the teaching and training. And finally, there are other instances in the patient's care that can be questionable situations. Can a patient do something? As a question to ask yourself. So for instance, determining if a patient is even capable of independent ambulation, if they're capable of dressing or feeding or performing hygiene. These are things that the skilled personnel need to first examine and determine and assess the patient's condition, and that is considered a skilled service as well. So generally, these are part of your overall assessment. And again, the assessment has to be done by you as a skilled personnel. So these are just some examples, and I do encourage you to go out and look at that section of the regulations that we put into the chat, because these are things that are going to help you determine if the service you provide is actually skilled or not. And then finally, some additional resources that I have put in here for you to just look at on your leisure. All right, so quick recap. We learned about the essential documentation requirements for skilled nursing facility services under Medicare. So we achieved that goal today, and we achieved that by reviewing those basic coverage criteria, and we discussed those documentation requirements and how these two really go hand in hand, how your documentation really needs to support the basic coverage criteria are met. Because if we can't see that it exists, we can't in turn give you Medicare money for that. Now, that takes us to the end of our formal presentation. And I know we are right at call end time, so I appreciate you that are able to give just a few more minutes. And I'm looking over into the chat, and I do not see anything that came into the chat, but I did want to address just two quick questions that came in before the presentation started. And the first one is, can an advanced practice practitioner bill for the initial comprehensive visit for SNF? And the answer to that is no. The APP or advanced practice practitioner generally cannot bill for that initial comprehensive visit in a skilled nursing facility because the regulations require the physician to perform and bill this specific visit. So while the advanced practitioners can perform other medically necessary visits and may be able to provide subsequent alternative visits, they can't perform or bill that initial comprehensive assessment that includes the physician plan of care and admitting orders. And then the next one is, what documentation is required and the span of time documentation is needed for a claim being reviewed. So basically all the required documentation to support the dates of service under review is what we need, as well as look back information to support the HIPS code build. And then again, any initial evaluations, that helps to support the progress and goals that are set by those skilled professionals. All right, and not seeing any other questions, I am going to move on. Again, I appreciate you giving me a few extra minutes here of your time. So in your mailbox right now should be an email from us, and that serves as your certificate of achievement. So don't delete it without reading it. It gives you that information in the body of the email that if you want or need to submit this for CEUs to your accrediting body, that you could use that for that. It also provides you a link to the survey if you choose to take it in that manner. If you have follow-up questions, please send those to me within the next 7 calendar days at this email address listed here, wps.gha.education@wpsic.com. Just put something in the subject line that it's about SNF documentation and go ahead and send those in. Jennifer's going to place a copy to our survey in the chat. I do encourage you to take our survey. It only takes a few minutes to complete. We wanted your feedback on this event and on how we did. And this is also your opportunity to tell us what additional education you would like for us to bring to you in the future, because many of these educational events that we provide are a direct result of requests that we get within our survey. So I do ask you to please complete that survey. The system's going to automatically redirect you to the survey once you close out of the webinar as well. So if you see something that looks like this external site, it's not spam, it's just WebEx's way of directing you to the survey. And finally, we're committed to making changes. So we do, again, want to hear from you. And then just based on some of the information that we have received, these are some of the changes that we've recently made. We've added chapters to our YouTubes and our Encores. So if you re-review via YouTube, you can click through the chapters to get to sections that you want to re-review. We've also added training indicators to our sessions and to our live events. So you know if sessions are pertinent to billing or if they're clinical in nature, if they're going to go over documentation or something regarding the FIS or MCS system, etc. Finally, I wanted to let you know that we are having a Medicare Education Expo coming up. And it's called Medicare Madness because it is in October. And in that Expo event, we are going to go through the life of a claim. So you have opportunities to tailor your day, attend all sessions, attend just a couple sessions that make sense to you. We're going to give an overall day of learning to our providers on basically how a claim process is, from enrolling as a provider all the way through to, you know, what happens when someone wants to review your claim. Who are those people that you may have to answer to? So I do encourage you to sign up for that. Jennifer also placed a link into the chat. And finally, on behalf of myself and Jennifer and all of Medical Review, I want to thank you for giving me these few extra minutes, and thank you for your participation in today's event. This concludes our webinar, and you may now disconnect.